Imagine walking into, the most prestigious conservative psychiatric hospital in the country. You walk past these massive mahogany doors, past the old oil portraits of the founders, and you step into a treatment room.
Right, you're expecting the standard clinical environment.
Exactly. But instead of a doctor just handing a deeply depressed patient a daily pill and, sending them on their way, you see two trained therapists. And they're settling the patient onto this comfortable sofa. They put an eye mask over their eyes.
That is the stage, yeah.
Right. They put on this highly curated instrumental musical playlist. And then in this sterile, globally respected medical institution, they administer a heavy, highly precise dose of psilocybin.
Which is the active psychoactive ingredient found in magic mushrooms.
Yeah. And I mean, 5 years ago, in almost any context, that action was a felony. But today, it is the cornerstone of clinical trials that have literally been granted breakthrough therapy designation by the FDA for treating severe treatment-resistant depression. Welcome to today's deep dive.
It really sounds like science fiction, doesn't it? Or maybe a throwback to the counterculture movements of the 60s.
Totally.
But the reality is just much more clinical, and frankly, it's much more complex. We are witnessing what is arguably one of the most significant paradigm shifts in modern psychiatric research. But before we get into the mechanics of why this is happening, I really need to establish a very rigid boundary for our conversation today.
Right, the disclaimer, because this gets misunderstood all the time.
Absolutely. The clinical framework we are investigating today is light years away from recreational use. I mean, we are not discussing, analyzing, or validating taking these substances at a music festival or, alone in your bedroom.
Yeah, this isn't a how-to guide.
Exactly. We are not providing a sourcing guide, and we are absolutely not endorsing self-treatment or underground experimentation. The psychoactive compounds we are exploring carry profound and sometimes deeply destabilizing psychological and physiological risks.
Which we will definitely get into.
Yes. So what's fascinating here is that our sole focus today is on a highly controlled, deeply experimental medical model, one that marries powerful pharmacology with really intensive, professionally monitored psychological support.
Okay, let's unpack this. Because that boundary is critical. It's the lens through which we have to view everything today. Because you, listening to this, you might be thinking, I had a terrible time on mushrooms in college. There is no way this cures depression.
All right, the bad trip association.
Right. Or, on the flip side, you might be thinking of the massive media hype promising this miracle overnight cure. And we want to cut through both of those, the extreme skepticism and the dangerous exuberance.
Because the truth is somewhere in the middle,
Yeah.
but heavily leaning toward rigorous science.
Right. And to understand why conservative regulators are suddenly pouring millions of dollars into this, we have to look at the massive glaring failure in our current system. We have to talk about the bottleneck.
The treatment bottleneck.
Yeah. In the clinical research, you see this phrase pop up over and over again, treatment-resistant depression, or TRD.
Right. And TRD, treatment-resistant depression, is a specific clinical categorization. And honestly, it represents just a staggering public health crisis right now.
How is it defined officially? Like, when does a patient cross that line?
Generally speaking, a patient gets a TRD diagnosis when they have not responded adequately to at least 2 different standard antidepressant trials. So typically your standard SSRIs or SNRIs.
Right, the daily pills.
Exactly. And that means administered at an adequate dose for an adequate duration. And I really want to clarify what we mean by adequate response, or rather the lack of one.
Yeah, because we aren't just talking about, a patient who still feels a little bit sad on a rainy Tuesday.
No, not at all. We're talking about patients whose core debilitating symptoms, like anhedonia, which is the inability to feel pleasure, profound lethargy, active suicidal ideation, severe cognitive fog, all that remains largely unchanged despite heavy pharmaceutical intervention.
Wow. So the drugs are literally just bouncing off them.
Basically, yes. The baseline measurements they use in these trials, like the MADRS score, which measures depression severity, show that these individuals are trapped. They are in a state of severe chronic suffering.
And there are a lot of these people, right?
Millions of people globally who are doing exactly what their doctors tell them, following the standard of care to the absolute letter, and they are getting zero relief.
I think we really need to put ourselves in the shoes of one of those patients for a second, just to understand the sheer desperation that's driving this research. So imagine you are that patient.
That's exhausting just to think about.
It really is. You finally gather the courage and the energy just to go to a psychiatrist. They prescribe a standard SSRI. And they tell you, well, you have to wait 4 to 6 weeks for it to build up in your system.
Which is an agonizing wait when you're severely depressed.
Oh, absolutely agonizing. And during those 6 weeks, you might get all the side effects before you see a single drop of benefit. You feel nauseous. You literally can't sleep. You might experience this profound emotional blunting.
Right, where the crushing sadness is still there, but now you just feel totally numb to everything else, too.
Exactly. So 6 weeks finally pass. You go back to the doctor and you say, I don't feel better. My life is still falling apart.
And standard protocol dictates the doctor will likely taper you off that first medication.
Which introduces withdrawal, right?
Yeah, often called discontinuation syndrome, which can include brain zaps, dizziness, and honestly, a worsening mood. Then they introduce a second medication, and that 6-week clock starts all over again.
And another 6 weeks of waiting. And maybe this new pill causes significant weight gain, or maybe it causes, complete sexual dysfunction. And at the end of it, the depressive weight hasn't lifted an inch.
And patients do this 3, 4, 5 times over a decade.
The sheer grinding exhaustion of that cycle is just mind-boggling to me. It really feels like a systemic failure.
It is, and it highlights a really fundamental limitation in our pharmacological toolkit. Because for the better part of the last 50 years, psychiatry has been dominated by what we call the monoamine hypothesis.
That's the chemical imbalance theory, right?
Exactly. This was the idea that depression was primarily a straightforward chemical imbalance. The thought was, you don't have enough serotonin, norepinephrine, or dopamine in the synaptic clefts of your brain, so you feel depressed.
Great. So the solution is just add more serotonin.
Right. Give a drug that blocks the reuptake of those neurotransmitters, artificially increasing their availability.
Mm-hmm.
But as this massive TRD population proves, just flooding the brain synapses with serotonin is not the silver bullet we thought it was.
So what's actually going on if it's not just a chemical deficit?
Well, for a massive subset of patients, depression becomes entrenched. It becomes this structural and functional rigidity in the way the brain networks actually communicate with each other.
Rigidity, meaning the brain gets stuck.
Exactly. The neural pathways that are associated with negative self-referential thought, that vicious inner critic that tells a depressed person they are completely worthless, that nothing will ever improve, those pathways become incredibly thick, dominant, and overactive.
Okay, so I've always thought the older analogies for antidepressants really fell short here. Like, people used to say taking an antidepressant is like putting a bucket under a leaky roof.
Right.
It stops the floor from rotting, but it doesn't actually fix the hole. But based on what you're saying about entrenched pathways, I think a better way to visualize this deeply entrenched treatment-resistant depression is to imagine the brain as a snowy hill.
A snowy hill, okay.
Yeah. And every single thought you have is a sled going down that hill. Now, if you have severe depression, your brain has been sending these negative ruminating sleds down the exact same path thousands of times a day for years.
That is actually an excellent visualization of neuroplastic rigidity.
Right. So over time, those sled tracks become deep, icy, inescapable trenches. Any new thought you try to have, like a positive thought or a hopeful thought, it just slides right back into that deep trench of despair.
It gets pulled in by gravity.
Exactly. And traditional daily antidepressants are essentially trying to push the sled out of the icy trench using sheer force. But the trench is still there. The landscape itself hasn't changed.
That's spot on.
So the question that seems to be pushing researchers towards psychedelics is like, are we reaching the absolute limits of what a daily maintenance-style chemical can actually do for a brain that is structurally stuck in an icy trench?
And that is the exact theoretical pivot that is driving this entire field. Researchers realize that just pushing the sled isn't working anymore. We actually need to alter the snowy hill itself.
We have to change the landscape.
Right. We need a mechanism of action that induces rapid, profound neuroplasticity. We need the brain to literally sprout new dendrites, to form new synaptic connections, to essentially rewire its rigid networks.
So, to use the metaphor, we need a fresh, heavy snowfall.
Exactly. We need a heavy snowfall that temporarily fills in all those deep, icy trenches, which allows the sled to take a completely novel path down the hill. And this realization that our traditional tools were just completely failing to induce this necessary structural change, it forced the medical establishment to look at compounds they had previously demonized. They had to look at psychedelics.
Which brings us to the actual therapy model. Because if the goal is just getting that fresh snowfall, people assume the drug is the only thing that matters. Just take the pill and the snowfall.
Right. which is a massive misconception.
Yeah, we have to fundamentally separate what is happening in a clinical trial from taking a substance recreationally. It is not just about the chemical.
No, the clinical model is built on a foundational understanding that the psychoactive compound is merely a catalyst. It is the snowfall, yes, but the therapy is the treatment.
That's a huge distinction.
It is. If a patient takes a powerful psychedelic in an unsupported environment, sure, they might experience a profound opening of their neural pathways. But without guidance, they are just as likely to carve a new trench of anxiety or trauma.
Because they're scared.
Exactly. The clinical trials you're reading about in the news employ an incredibly rigid, mandatory three-phase therapeutic model.
Okay, let's break those phases down because just the time commitment alone is absolutely staggering. Yeah. Phase 1 is preparation. You don't just walk in, show your ID, and get a dose of psilocybin.
No, definitely not.
You spend weeks, multiple sessions with 2 specially trained therapists, and you are mapping out your psychological history, your traumas, the specific, architecture of your depression.
And crucially, during this time, you are establishing psychological safety. In psychedelic research, there is this core concept known as set and setting.
Set and setting.
Right. The set is the mindset the patient brings into the experience, and the setting is the physical and interpersonal environment. If the set and setting are not meticulously curated to evoke deep trust and safety, the physiological vulnerability induced by the substance can be absolutely terrifying.
Because your defenses are totally down.
Exactly. So during preparation, therapists actually teach patients how to navigate intense, overwhelming anxiety. They teach a concept of inward focus and surrender.
What does that mean in practice? Surrender.
Well, say you see a terrifying monster in your mind's eye during the session. The instruction is, you don't run from it. You actually ask it what it represents. You move toward the fear.
Wow. That goes against every human instinct.
It really does. And you simply cannot teach a patient to do that effectively 5 minutes before administering a highly potent psychoactive compound.
They need weeks of prep. Okay, then we get to phase 2, the monitored dosing session. This is the big 8-hour day. And the room doesn't look like a surgical suite. It looks like a cozy living room.
Yes, very intentionally designed.
And the patient puts on eye shades, which I find really fascinating because it forces the whole experience entirely inward. You aren't, staring at the wall watching it breathe. You are exploring your own internal landscape. And the music playlist is specifically designed to follow the pharmacokinetic arc of the drug. So it builds in intensity as the drug peaks, and then it calms down. And those 2 therapists they just sit there.
They sit there, they monitor physiological vitals, and they hold a safe container. They are largely non-directive.
Meaning they aren't interviewing the patient.
Right. They are not trying to do talk therapy while the patient is actively under the influence. If the patient is thrashing or weeping or experiencing what we call an ontological shock, which is a complete dissolution of their sense of self, the therapists are there to offer a hand to hold.
To ground them.
Yes, to remind the patient they are safe and to encourage them to stay with the difficult material.
Okay, and then comes phase 3, which, from my reading of all this literature, is where the actual healing really happens, and that's integration.
Integration is vital.
I read this transcript from a Johns Hopkins trial, where a therapist used just a brilliant metaphor. They told the patient, the dosing session is like shaking up a snow globe. All the snow is swirling around in total chaos. But integration is the process of deciding where the snowflakes are going to land.
I love that analogy.
Yeah.
Because the trip isn't the cure.
Right. The trip isn't the cure.
No, the trip is just a window of neuroplastic opportunity. And that window can last a few days to maybe a few weeks after the substance completely leaves the body.
Okay.
So integration therapy, which happens in the days and weeks following that dosing session, is the grueling work of making sense of abstract, deeply symbolic, and often incredibly painful imagery.
Like the monster you were talking about.
Exactly.
Yeah.
A patient might have experienced a profound sense of interconnectedness, or they might have confronted a deeply repressed memory of childhood neglect. In integration, the therapist helps the patient translate that raw, chaotic emotional exposure into tangible behavioral changes.
So bringing it back to real life, yes. How does this experience change the way you speak to your spouse? How does this alter your core belief that you are inherently unlovable?
Right. But let me play devil's advocate here for a second, looking at this from a purely biological standpoint, because we live in a highly medicalized culture, right? We are so used to the chemical doing the heavy lifting.
Or we really are.
So if this compound is so incredibly powerful that it's physically forcing the brain to sprout new connections and, shaking the snow globe, why do we need dozens of hours of really expensive talk therapy? Doesn't the neuroplasticity just kind of fix the brain automatically?
That is the most common and honestly perhaps the most dangerous misunderstanding of neuroplasticity.
Really?
Yes. Neuroplasticity is simply a state of malleability. It just means the brain is highly capable of change in that moment. But neuroplasticity is entirely directionless.
It does not inherently know what is good or healthy for you. So if you artificially pry open a window of massive neuroplasticity and the patient is terrified, alone, unsupported, and they fall right back into their typical depressive rumination while in that highly suggestible state.
They just build a new trench.
Worse. They might actually reinforce and strengthen those negative neural pathways. The brain will simply wire the trauma deeper.
Wow. So you could actually make them worse.
Precisely.
Yeah.
The therapy provides the scaffold for the neuroplasticity. The chemical blasts the door open, sure, but the therapy is what walks the patient through it into a healthier room. This is exactly why researchers absolutely adamantly oppose the idea of just prescribing these pills for people to pick up in a pharmacy and take it home.
Okay, that makes total sense. But if the goal is just forcing the brain to sprout new connections quickly, we don't necessarily have to look at illegal psychedelics, do we?
Yeah.
Because my understanding is that anesthesiologists and psychiatrists have kind of been doing this accidentally for years with ketamine.
Yes, ketamine is a huge part of this conversation.
So let's look at the actual substances being used here, because they are very different from one another.
They are pharmacologically distinct,
Yeah.
and they are navigating completely different legal and clinical pathways. So let's start with ketamine, because it is the most accessible right now.
Right.
Ketamine is not a classic psychedelic. It is a dissociative anesthetic. It has been FDA approved for decades for use in operating rooms. But researchers discovered that when administered at sub-anesthetic doses, so a tiny fraction of what you'd use to put someone under for surgery, it produces rapid, profound antidepressant effects.
And because it's already an FDA-approved drug, doctors have the legal authority to prescribe it off-label for depression right now. I mean, you can literally drive down the highway and see a billboard for a ketamine clinic.
Yes, you can. It is serving as the current legal bridge to this whole new frontier of rapid-acting mental health treatments. But its mechanism is entirely different from classic psychedelics.
So,
Ketamine primarily targets the glutamate system in the brain, specifically blocking NMDA receptors. Now, glutamate is the brain's primary excitatory neurotransmitter. By blocking these receptors, ketamine triggers a cascade of events that leads to a massive, rapid burst of synaptic plasticity in the prefrontal cortex.
so the fresh snowfall again?
Exactly. Patients in severe distress, sometimes actively suicidal, can receive an intravenous infusion of ketamine and report that the crushing weight of depression has lifted within hours.
Within hours. I mean, compare that to the 6-week waiting game with SSRIs we talked about earlier. It's staggering, but there's a catch with ketamine, right?
There is. The catch is durability. While the relief is rapid and literally life-saving in acute crises, for many patients, the antidepressant effect is transient.
Meaning it fades.
Yes. It might last a few days or a couple of weeks. The brain tends to revert back to its old pathways. This is why the field is realizing that even with ketamine, the therapeutic wraparound, the preparation, and the integration therapy is totally vital.
Right, you can't just take the infusion and go back to work.
No, you have to use that brief window of chemical relief to do the heavy psychological work required to actually sustain the gains.
Here's where it gets really interesting, because that brings us to the classic psychedelics and empathogens compounds like psilocybin and MDMA.
Right, the Schedule I drugs.
Exactly. These were placed on Schedule I of the Controlled Substances Act decades ago. The government literally declared they had no currently accepted medical use and a high potential for abuse. They were the ultimate public enemies in the war on drugs.
And yet
Today, the data coming out of places like Johns Hopkins and MAPS is so undeniable that the FDA had to use its breakthrough therapy mechanism to fast-track their research. Let's unpack the how here. What is psilocybin actually doing to the depressed brain?
Well, to understand psilocybin, we have to look at a specific network in the brain called the default mode network, or the DMN.
The DM, yes.
Think of the DMN as the brain's orchestrator, or its CEO. It is a network of interacting brain regions that is highly active when you're awake, but not actively focused on the outside world.
So when I'm just sitting in traffic, chewing on my own thoughts, wondering if I embarrassed myself at a meeting yesterday, That's a DMN running the show.
Exactly. It's active when you are daydreaming, recalling memories, envisioning the future, and most importantly, when you're thinking about yourself. It is the neurological seat of the ego, the autobiographical self.
Okay, so what goes wrong with it in depression?
Well, in a healthy brain, the DMN is flexible. It turns on, it turns off.
Yeah.
But in a severely depressed brain, functional MRI scans show that the DMN becomes hyperconnected and hyperactive. It essentially becomes a tyrant.
A tyrant.
Yes, it forces the brain into an endless loop of rigid, negative, self-referential rumination. It's that inner voice saying, you are a failure, nothing will work out, you are fundamentally broken.
It's the deep, icy sled trench.
Yes. So psilocybin, which is a classic psychedelic, acts primarily as an agonist on the serotonin 2A receptors.
The 5-HT2A receptors, right.
Correct. When these receptors are stimulated by a heavy dose of psilocybin, something remarkable happens to the DMN. It essentially powers down. The rigid connectivity within the DMN temporarily disintegrates. The CEO leaves the building.
Wow. And what happens to the rest of the brain when the CEO leaves?
Chaos, honestly, but a highly therapeutic kind of chaos. When the DMN goes offline, all these other parts of the brain that normally never speak to each other suddenly start communicating.
Like crosstalk.
Exactly. The visual cortex starts talking to the auditory cortex, which is why people might actually see music. But more importantly for depression, the rigid, overused pathways of self-hatred are completely bypassed. The brain explores completely novel patterns of connectivity.
So the patient gets a break from themselves.
Yes, patients often report experiencing a profound sense of ego dissolution. Without the DMN enforcing the narrative of, I'm a depressed, broken person, the patient can view their life, their trauma, and their very existence from an entirely objective, often radically compassionate perspective.
That is just fascinating. So psilocybin literally takes the mechanism of rumination offline. But then we have MDMA, which is moving through clinical trials primarily for severe treatment-resistant PTSD. And MDMA is doing something entirely different, right? Because it's not a classic psychedelic, it's an empathogen.
That's right.
Explain the mechanism there, because treating trauma is notoriously difficult.
Treating severe PTSD is incredibly difficult because of the brain's threat detection system.
Yes.
Specifically, the amygdala.
The amygdala.
Right. Think of the amygdala as the brain's fire alarm. When you experience trauma, the amygdala links that specific memory to a profound physiological fear response to keep you safe in the future.
So you don't repeat the mistake.
Exactly. But in severe PTSD, that fire alarm gets glued in the ON position. So if a therapist asks a patient with severe PTSD to just recall their trauma so they can process it in talk therapy, the amygdala instantly blares.
Their body just panics.
Yes. The body floods with cortisol and adrenaline. The patient goes into a state of hyperarousal or dissociation. The prefrontal cortex, which is the logical learning part of the brain, literally shuts down. The brain refuses to learn or process because it thinks it is currently under mortal threat.
Wow. You literally cannot do talk therapy because the biological hardware is screaming danger.
Precisely. And this is where MDMA's pharmacology is so elegant for trauma. MDMA promotes a massive release of serotonin, dopamine, and crucially, oxytocin.
The bonding hormone?
Yes, oxytocin is the hormone associated with bonding, trust, and safety. But simultaneously, and this is the key functional imaging, shows that MDMA significantly decreases blood flow and activity in the amygdala.
So it chemically unplugs the fire alarm.
Yes, it chemically unplugs the alarm while wrapping the patient in a neurochemical blanket of safety and profound self-compassion.
That's incredible.
It is, because for the first time, perhaps in decades, the patient can consciously walk into the burning building of their traumatic memory, pick it up, examine it from all angles, and process it without their body triggering a massive panic attack.
Yeah.
They can reconsolidate that memory without the paralyzing terror attached to it.
Hearing the biological mechanisms laid out like that, unplugging the amygdala, taking the DMN offline, it's incredibly hopeful. But this is exactly where we need to pump the brakes.
Yes, we do.
Because any substance powerful enough to systematically dismantle your ego and alter the fundamental architecture of your brain's fear center, that carries massive, terrifying risks. And the media often completely ignores this.
They absolutely do, and it is a truly dangerous oversight. The reality of these clinical trials is that patient selection is a rigorous, agonizing process. The inclusion criteria are narrow, and the exclusion criteria are exceptionally strict.
Meaning this therapy is fundamentally not for everyone.
Emphatically not for everyone.
So let's talk about those exclusions. Who gets turned away at the door of these trials and why?
Well, anyone with a personal or immediate family history of psychotic disorders, such as schizophrenia or bipolar disorder, particularly with a history of mania, they are categorically excluded.
Why is that?
The reason is pharmacological. The profound psychological altering induced by classic psychedelics, that disruption of the default mode network we just talked about, it can act as a trigger.
Like lighting a match.
Exactly.
Yep.
In a vulnerable individual, it can precipitate a severe manic episode or trigger a latent psychotic break from reality that they literally may not come back from. We also exclude patients with severe, unmanageable anxiety, active substance use disorders, or certain cardiovascular conditions, because these substances temporarily but significantly raise blood pressure and heart rate.
I think we need to visualize the human element of this screening process because it's heartbreaking. Imagine a lead clinician running one of these high-profile trials. A patient comes into their office, and this patient is the definition of desperate.
We see it all the time.
Right. They have lost their job, their marriage is failing, they have tried 15 different medications, and they are begging for a chance to try this new therapy they read about in a magazine. But during the psychiatric intake, the clinician discovers the patient has an aunt with schizophrenia, or maybe the patient themselves had a brief manic episode in their 20s.
That clinician has to say no.
Yeah. That clinician has to look this desperate, suffering person in the eye and say, no, I cannot help you. They have to balance the patient's urgent need for relief against the statistical risk of triggering a permanent, catastrophic psychological event. The ethical burden on these researchers is just immense.
It is a devastating conversation to have, but it is clinically vital. And if we connect this to the bigger picture, this brings us to a fallacy that plagues the public discourse around these substances.
The natural fallacy.
Yeah.
Oh, I hear this constantly. People say, well, psilocybin comes from a mushroom that grows in the dirt. Our ancestors used it. It's natural. Therefore, it's inherently gentle, safe, and holistic. And I always want to point out to them that arsenic is natural. Cyanide is 100% natural.
Exactly. The natural fallacy is dangerously misleading in psychopharmacology. The origin of molecule, whether it was synthesized by a fungus in the soil or synthesized by a chemist in a sterile laboratory, has absolutely no bearing on its safety or its profound impact on human neurochemistry.
A chemical is a chemical.
Right. A psilocybin experience, regardless of its natural origin, can induce what we discussed earlier, ontological shock.
The shattering of reality.
Yes. For a meticulously prepared patient in a safe, guided setting, the dissolution of their reality can be profoundly therapeutic. But for an unprepared, vulnerable patient, or someone just taking it recreationally to see colors, the sudden realization that their ego is dissolving can be utterly terrifying.
It can cause actual harm. Significant harm. It can induce massive panic attacks, severe derealization, or even worsen their existing trauma. The danger lies in the sheer intensity of the psychological journey.
Which leads right into the danger of media hype, because you see these magazine covers, right? The mushroom cure, or how MDMA is fixing depression. The language implies a silver bullet.
It's so irresponsible.
It really is. And that hype does two incredibly destructive things. First, it completely bypasses the concept of informed consent. Patients need to know that this is not a breezy afternoon at a spa.
Oh, it is grueling work.
Yeah, they might have to face the darkest, most terrifying, deeply repressed parts of their psyche. They might sob for 4 hours straight. And second, the hype ignores the failure rate, because there are people who go through the weeks of prep, the 8-hour dosing sessions, the integration, and at the end of it, their MADR depression score hasn't dropped.
It doesn't work for everyone.
It doesn't. And the necessity of informed consent is paramount here. If the media promises a quick fix, patients enter the experience with completely skewed expectations. Right. And when the medicine brings up a terrifying trauma instead of a kaleidoscope of pretty colors, the patient resists, they panic, and the therapeutic potential just completely collapses.
Because they fight it instead of surrendering.
Exactly. Furthermore, this exuberant media hype is creating a significant public health hazard because of the regulatory bottleneck. It is driving desperate, suffering people to seek out unregulated, underground practitioners.
And that gap between research and reality is the Wild West we are currently living in. Let's look at the regulatory and ethical landscape in the United States right now, because it is an absolute mess of contradictions.
A total mess.
On one hand, the FDA is saying, yes, the data is incredible, we are giving this breakthrough therapy status. But on the other hand, the substance remains federally illegal.
The FDA is in a profoundly difficult position right now. Their mandate is to ensure both safety and efficacy. And evaluating this specific model is a logistical nightmare for a regulatory body.
Because they regulate drugs, not therapy.
Exactly. The FDA is designed to evaluate drugs. They approve a pill, you take it at home, but they do not regulate the practice of medicine or psychotherapy. That is left to state medical boards.
So there's a huge jurisdictional gap.
Massive. So if the data clearly shows that psilocybin is only safe and effective because it is administered alongside 40 hours of highly specialized psychotherapy, how does the FDA approve the drug while enforcing the therapy?
How do they police that?
They can't. How do they guarantee that a clinic in rural Ohio is maintaining the exact same psychological safeguards as the clinical trial at Johns Hopkins?
That is the regulatory nightmare. And while the FDA tries to figure that out, we have this massive ethical danger playing out on the ground right now. Because people read the headline, FDA fast-tracks psychedelics, and they confuse fast-track research with approved medical treatment.
Which happens every day.
Yeah. So a desperate patient finds a retreat center abroad or maybe an underground guide in their city. They pay thousands of dollars, they take a massive dose, they have a deeply destabilizing psychological earthquake of an experience.
But there's no follow-through.
Exactly. The retreat ends on Sunday. There is no weeks-long integration phase. They are just sent back to their daily life with their neuroplastic window wide open and all their psychological defenses completely stripped away. They are left worse off than when they started.
This is the exact scenario clinical researchers fear the most. The underground landscape has varying degrees of competence, sure, but it fundamentally lacks standardized screening, medical monitoring, and rigorous integration.
Right.
But this raises an important question. Even within the legitimate clinical trials, we have to acknowledge massive methodological limitations. And this is where we have to look critically at the data itself, because the gold standard of medical research is the double-blind, placebo-controlled trial.
Right. And this is arguably the worst-kept secret in the history of clinical trials.
It really is.
Like, in a normal trial for, say, a new cholesterol medication, you give Group A the real drug and Group B a sugar pill. Neither the patient nor the doctor observing them knows who got what. That's the double-blind. It eliminates bias.
Standard practice.
Right. But if you are running a trial with a massive dose of psilocybin, you give one patient a sugar pill, and you give another patient 25 milligrams of synthetic psilocybin. Within 45 minutes, the patient who thinks the wallpaper is melting into geometric patterns knows exactly which group they're in.
Unmistakably.
And the therapist watching them knows, too. The blind is instantly blown to pieces.
It is a critical methodological flaw, and it introduces a massive variable called the expectancy effect.
The placebo effect on steroids?
Basically, yes. If a patient with severe depression enters a trial hoping for a miracle cure, and 45 minutes in, they realize they received the active dose, their expectation of getting better just skyrockets. That hope alone has a profound antidepressant effect.
And the reverse is true too, right?
Yes. Conversely, if a patient realizes they only received the placebo, they experience a crushing wave of disappointment, which can artificially worsen their depression scores.
I know researchers have tried to solve this by using active placebos, right? Like giving the control group something else.
Yes. They try to use drugs like niacin, which causes a physical flush and tingling, or very low subperceptual doses of the psychedelic itself.
Just to trick them a little.
Right. The goal is to cause just enough of a physical sensation to make the patient wonder if they got the active drug. But frankly, it is an imperfect solution. The psychological journey of a high-dose psychedelic is unmistakable. This means the data we have, while incredibly promising, is much harder to interpret definitively than a standard pharmacological trial.
We also have to challenge the data on the durability of the treatment. Okay, so the patient's MADRS score plummets at the 6-week follow-up. They feel great. But what about 6 months later?
Or a year later.
Right, what about 2 years later? Are these trials even designed to capture the long-term psychological trajectory of someone who just had their entire worldview shaken up?
That is the frontier of the current research. The durability varies wildly. For some patients, a single protocol of preparation, dosing, and integration provides profound relief that lasts for over a year, or even indefinitely. Yeah, they genuinely change their life architecture. But for others, the depression begins to creep back after 3 to 6 months. This suggests that for many, this is not a one-and-done cure, but a treatment that might require periodic booster sessions.
And that realization forces us to confront the looming reality of healthcare economics.
The money problem.
And this is where the rubber meets the road. Let's say the FDA figures out the therapy mandate. Let's say it gets approved. We are not rolling this out into a utopian healthcare system.
Definitely not.
No, we are rolling this out into the United States' highly fragmented, for-profit insurance model. I am looking at this 3-phase model. Weeks of prep, an 8-hour guided session with 2 highly trained therapists, plus weeks of integration. From a healthcare economic standpoint, this is a nightmare.
It's completely antithetical to how we practice medicine right now.
Our entire insurance model is built on efficiency, handing someone a generic pill and a 15-minute medication check. How much is an 8-hour session with 2 specialists going to cost?
The estimates are very high. Without insurance coverage, a single round of psychedelic-assisted therapy could cost tens of thousands of dollars. And the ethical implications of this are staggering. Are we spending millions of research dollars just to create a boutique miracle treatment for the wealthy?
Exactly. The people who might benefit the most, individuals whose depression is rooted in systemic trauma, poverty, or severe marginalization, they will be entirely priced out.
And the danger of the for-profit system is that the market will inevitably demand efficiency. There will be immense financial pressure from insurance companies and corporate clinics to cut corners.
They'll try to streamline it.
Yes. They will ask, do we really need 2 therapists? Can we just use 1? Can we cut the preparation phase down to an hour? Can we skip the integration entirely?
And the moment you cut those corners, you remove the clinical scaffold.
Precisely. If you remove the scaffold to save money, patient safety is directly compromised. The risk of traumatizing a patient just skyrockets. The integration is not an optional add-on. It is the core mechanism of translating the chemical experience into lasting psychological change.
So we have covered an immense amount of ground today. We started with the sheer exhaustion and failure of traditional treatments for the treatment-resistant population.
The bottleneck.
Right. We dismantled the idea that this is just taking drugs, exploring the intensive mandatory framework of preparation, the 8-hour dosing session, and the absolutely vital integration phase.
That therapy is the treatment.
Exactly. We broke down how ketamine forces rapid plasticity, how psilocybin takes the ego's default mode network offline, and how MDMA unplugs the amygdala's fire alarm so patients can finally process trauma.
But we also look at the hazards.
We did. We looked at the very dark reality of who is excluded, the profound risks of ontological shock, and the chaotic, frankly terrifying regulatory and economic hurdles standing in the way of actual clinical access.
Right. So if we are to synthesize all of this clinical data, history, and regulatory tension, the core message is really this. Psychedelic-assisted therapy undeniably represents an incredibly important, potentially paradigm-shifting way that we understand and treat entrenched depression and trauma.
The data is there.
The data we have, even with the blinding flaws, is too significant to ignore. However, the future of this field absolutely depends on evidence, not enthusiasm. It relies entirely on strict regulation, extremely careful patient selection, uncompromising clinical safeguards, and responsible ongoing medical oversight.
Because it's not a magic trick.
No, without the intensive therapeutic framework, the psychoactive substance alone is not a treatment. It is just a disruptive chemical event.
And for you listening, that is the most critical takeaway from this entire deep dive. Mental health treatment decisions always require qualified, professional evaluation. We are looking at a frontier of medicine that is full of legitimate promise, but media hype should never replace clinical caution. There are no magic pills, and despite the headlines, there are no magic mushrooms that bypass the hard, grueling work of psychological healing.
Well said.
As we wrap up today's deep dive into the evolving frontier of mental health, I want to leave you with one final thought to mull over. We've talked about how this therapy forces the brain to rewire itself. But what about our medical system?
That's the million-dollar question.
It is. If these highly intensive, heavily supervised therapies do eventually pass the FDA hurdles and become a mainstream approved reality, how is our medical infrastructure going to adapt? Will we have to completely redesign the architecture of how we deliver healthcare?
It's hard to imagine how we don't.
Because right now, our system is built almost entirely around the 15-minute high-volume medication check. Can a system designed for quick-fix pharmacology ever truly accommodate a therapy that requires 8-hour sessions, deep emotional vulnerability, and profound, ongoing human connection?
We will have to see.
We started this deep dive by talking about how the X-ray machine is broken when it comes to mental health. Maybe fixing the machine doesn't just mean finding a new lens. Maybe it means we have to rebuild the entire hospital from the ground up. Thank you for joining us on this deep dive.